Good morning. Welcome to MED220 90AX, and it is Friday morning, 10 a.m. as per the instructions here on the announcements. Week 7. So what's due today? Please email me. Excuse me. Thank you. Please email me. I believe I put it here. Let's see if I put it in the announcements. Here you go. This EKG homework. The homework assignment below is due today. I'll stretch it till closing of business today. So if you have not emailed me this homework here, please do so by closing of business. And that was last week. And what are we doing this week? It is week 7, so it's topic 7. We're going to be talking about phlebotomy. I will also then in the announcements put in a little bit phlebotomy homework to keep ourselves honest. Then next week, we are on campus. The lecture will be on campus. It'll be on urinalysis. We will have a urinalysis laboratory and EKG laboratory on that day, which is next Friday. Now, if you can't make it, I have Saturday makeup laboratories at 10 a.m. So please email me if you can't make next Friday's 9 a.m. session. Okay. And week 9, we're on campus. And week 10, we're on campus. And again, email me if you can't make any of these dates so I can, you can come to campus, because we need to be on campus because this particular course is listed and rated as a hybrid course. So legally, we have to meet on campus at least twice. And anyway, you also paid for laboratories. I could talk out of my ears about these procedures all day, but until you actually do them, and I recall you guys haven't had your EKG class yet, so it's really good to come in. And there's only 3 of you, so I don't think we're gonna have any distancing or COVID issues. And we have COVID protocols in effect. It'll be in Health Lab 1, 4th floor, Alexandria campus. Try not to mingle with anybody. All the common areas have been blocked off. There may be nurses in the building. They have to go directly to their labs. Don't hang out. Go directly to Health Lab 1, right? Masks are to be worn at all times. You must wear scrubs and or lab coat. If you don't have one, I could provide one for you. Do not bring too many personal items. Your car keys, cell phone, that should be enough, right? And we're going to put them on the side of the room and separated from anybody so that we have no contact with anybody. We will scrub in and glove in before, during, and after the laboratory. We can't loiter. Once the laboratory is done, we ask any questions. If not, scrub out and then leave campus. Don't hang out. Don't try to talk to another department like student accounts or whatever. And anyway, you can't just go see them. It's by appointment. Week 9, we'll do the phlebotomy laboratory, and we're going to have a quick review on the final exam. And the final exam will be on campus, written final exam, 50 items, multiple choice, on campus, same place, 9 a.m. on that Friday during week 10. And again, if you can't make these dates, give me a call, shoot me an email so that, it's okay to take the exam early, but it's not okay to take it late, because that week, I have to put in my my grades the very next day at 12 noon, and I'm preparing for the very next term. So there will be no opportunities for any makeup or anything like that. The window for it is too short and too small. Okay, what is this? Pacific Islander Day. I don't want to hear my options. Leave me alone. All right. Okay, so let's jump right into the phlebotomy procedure. And Has anybody taken their phlebotomy class yet? Have you taken your phlebotomy class?
No, I haven't.
No, I haven't. So okay. So let's go over this phlebotomy procedure and let's do it via video. Are you afraid of needles?
No.
No? Okay, good. Because I'm afraid of needles. This is the irony of it. I still get tensed out when they take blood from me. But giving needles, I got no issue with. But knowing that and understanding that it is an invasive procedure. That means you could be putting something into your patient. And we already know that our skin is teeming with Staphylococcus aureus, Staphylococcus epidermidis. There's also things in your hair and your skin called dermatophytes. There's like little buggies. If you don't know that, sorry to freak you out about that. But just imagine if I didn't do my asepsis or I didn't clean the area properly. When I insert that needle, what's going to be inserted as well? All that bacteria and all that foreign body, venipuncture. And venipuncture is a nice word. Let's see. Let's go over. It's called Vacutainer Procedure. Now there's three, and we're gonna go. I'm gonna show you 3 videos and do commentary on these 3 videos on how to take blood. And the first method is called Vacutainer. So if you see here, these are the ones with the little color top tubes, and they're already it's already a natural, not natural, but there's already a vacuum in it. So when you're looking at the needle, let's look at the parts of the needle before we begin. If you're looking at this thing, you see this here. This is a safety protection device that after you stick, this will go over. Why can't this enlarge? There you go. This will go over the needle and protect you and your patient. But inside here, you see this little gray thing? Once you screw this needle in, there's a needle here and there's a needle in there. And the second you put this Vacutainer tube and you put it all the way, it's going to start sucking up blood because it's a vacuum in there, right? So that's why they call it a Vacutainer system. And this thing right here is called a needle holder. And also the slang for it is a barrel. You might even, sometimes they call them barrels. You either have them here without any protective. Now this, I don't know now about the COVID protocols because everything in the COVID protocols is now enhanced. This is annoying. So everything about the COVID protocols is enhanced. So back in the, well, not even back in the day, a year ago before COVID, you could reuse this up to 3 times as long as there's no blood on it and it didn't get contaminated. But if you have this, this needle protector here, this is only a one-use item. But back in the day, even with these protectors in here, I used to just rip these off and then just reuse these. It was just cost effective. But nowadays, because of COVID and because of the enhanced PEP and the enhanced aseptic technique, think of this as a one-use item. And after we're all done, you put it all in the sharps. Everything goes in the sharps. So that's the Vacutainer method. That is the standardized method on how to obtain blood from a vein. And why veins? Veins are superficial and they are low pressure. So if you poke a hole, it would like the blood wouldn't come out like squirting out. It would ooze itself out under low pressure. And if you also notice, if you look at venous blood, let's look at that. If you look at venous blood, here's a nice picture. These are syringes. These are probably taken from an arterial blood gas. You see how red it is if it's arterial? And remember, arterial blood has red blood cells that carry mostly oxygen. So it's oxygenated, so it's going to look bright red. But the blood that we're taking with venipuncture, also known as phlebotomy, phleb means vein. Do you see how dark it is? And this is deoxygenated blood. And the deoxygenated blood, that's what it should look like. Okay? So let's look at this, and I'm going to make some comments. It may or may not be up to our snuff, but let's look at this. Oh, venipuncture procedure just from 7 months ago. And let's look at that, because this will have stuff that was pre-COVID. So let's look at this one.
As a medical assistant, you will need to know how to draw and collect blood samples. This procedure can be referred to as both venipuncture and phlebotomy. In this video, I'll be using the term venipuncture, and I'll first walk you through some important principles and considerations behind the procedure. Then, I'll show you how to perform a venipuncture procedure using a multi-sample needle with an evacuated tube system. This demonstration reflects how we teach venipuncture at Portland Community College, and though you will eventually work in a healthcare setting where the details of this process may vary, the overall procedure should be consistent from place to place. Before we get it,
I like that comment that it might vary. Whatever your protocol is at your facility, you follow that to the letter of the law. The protocol that we follow here is approved by, of course, your textbook, OSHA, NACLS, there's American Association of Medical Assisting, a whole bunch of people. So the procedure sheet that I'll show you after this video is the most correct way, but it's not the only correct way. And again, I have to say this because a couple of years back, I had a medical assistant who was removed from her her site because she didn't listen to her office manager when her office manager, who was a phlebotomist, was telling her to do a variation. And she said, well, this is the way Dr. Garais taught me, and I'm not going to change. And that's just stupidity. So don't do that. Right? We teach you the most correct way, but it's not the only correct way. There are other variants to this procedure.
The details, let's talk about 3 overarching considerations that are key to any venipuncture procedure. The first consideration is safety, and that includes the safety of everybody involved. The second consideration is patient experience. The goal here is for the patient to have a comfortable and supported experience throughout the procedure. And the third overarching consideration is specimen viability. It's critical that we appropriately handle and process the samples that we collect in order to ensure the accuracy of the test results. Each step in the venipuncture procedure will tie back to one or more of these 3 considerations. Now let's jump into the procedure itself. Once you have received an order for blood testing from a licensed provider, created a lab order, looked up processing information in a lab test directory, and made a plan, then it's time to prepare for the venipuncture procedure by gathering the necessary supplies.
Now, we're going to be showing you that in a moment. Well, I'll show you that now, because since it's part of this. If you look here on your topic 7, you're going to see here a sample requisition form. So when I click on that, you need an order, okay? So it goes, since you're not the physician or the DMP or the DO, this ordering provider has to be filled out or at least signed, right? The places that I have stars, that's like a must. And if you, this is so annoying. What is going on here? If your physician has this thing called the TRODAT or TRUDAT, it's this thing. TRUDAT or this thing, you know, the stampy thing, right? The pre-inked stamping machine. Be careful with these things. Trodat, T-R-O-D-A-T, not Trudat. The Trodat, this thing right here, this thing is just as viable as your physician's signature. Many of them are custom and has not only your physician's signature, it has their UPIN, which is the Universal Personal Identification Number. That is like the social security number of your office. Like the office of Dr. C.Garais will have a specific UPIN. Another set of numbers that this Trodat will also have the DEA number, and it will also have my license number. So all of these things are quite valuable. So usually the doctor has this on a keychain, usually connected to their person. But some other doctors, if it's office-based, have it in a drawer somewhere. But make sure that that thing gets protected, because you could easily use it to stamp this. So if the physician gave you a verbal order, you stamp this right here where it says ordering provider. And since this form is usually in triplicate, I stamp it on all the copies. And then verbally, or if the doctor wants to start checking and Xing off. Now, did you see the way I did my check marks? Right? Make sure that it is clearly on the box that it's provided right here. So there's no confusion on what I'm ordering. I'm ordering a CBC with diff, a glycosylated hemoglobin here, glucose outright, and TSH, which is thyroid stimulating hormone, right? So we know that was and of course, in your electronic medical record or in your paper record, you make sure that this gets recorded. Like Dr. Garais told me to do this, this, and this, order was filled out, and Trodat was utilized for the ordering provider space. Now, if you don't have time to put all these things in, like the patient's name, date of birth, collection time, and all this stuff, the priority for me, and in my past experience, of course, full name, first name and last name, and date of birth, and this ICD code. ICD-10 is your coding for your diagnosis codes. And you look it up real quick, and you could even Google it, like whatever the doctor is thinking about. Or let's say they came in with a cold, I Google, rhinitis, and then put the ICD code there, right? And of course, bill to the insurance. This is important because if this isn't filled out correctly, it's going to go straight to the patient as self-pay, and your patient's going to be pissed. They're going to be very upset, and they're going to be like, why do I got to pay like $80 or whatever, right? So this is your typical requisition form, okay? And see this? There's going to be a barcode, and there's going to be a strip of stickers with this barcode and with this number on it. Okay, that's important, which we're going to be talking about in a moment. So this is required, okay? Do not do something that you are not ordered to do, right? But if it's verbal, of course, what do? You document it and you put this in, okay? So back to the video. Let's now talk about the supplies for asepsis and for carrying out this procedure. Okay, whatever.
The supplies needed will include a tourniquet, 70% isopropyl alcohol wipes.
That's a common question on exams.
Cotton or gauze. Tape.
I like gauze in the separate packages.
The required Vacutainer tube or tubes needed for testing. Multi-sample straight needles, usually 21, 22, or 23 gauge.
And we're going to talk about the colors of the tubes and the needles.
Also known as adapters. The ones shown here have a needle safety guard, and you'll need to make sure that either your tube holders or your needles have these safety guards. Additional supplies include a biohazardous sharps container.
And you know it's sharps because it'll say
so. A lab order, specimen transport bag.
All right, let me talk about the bag. the bag is usually in two parts. And analyze and look at your bags. One part is clearly for the paperwork, and the other part is clearly for the specimen. Now, the paperwork part, I believe it has like a Ziploc top, but the specimen part definitely has that, you know, that wax, so that once you seal it, it's kind of hard to break the wax. So make sure your stickers with the barcodes are on your specimens, and the paperwork never leaves the specimen. So all of this has to stay together.
Hand sanitizer and disinfectant wipes. Additionally, this procedure requires the use of PPE, or personal protective equipment, including well-fitted, non-sterile, non-latex gloves, a face mask, a face shield, and a gown with full-length sleeves that is fully buttoned.
So they also have smocks now. This is now face shield and mask. This is now mandatory in a clinical setting for even non-invasive procedures such as EKG.
As disease prevention methods evolve, so will required protocols for PPE use. Once you are prepared to perform a venipuncture procedure and are face-to-face with the patient, you should always start with these three initial steps. Step number one is self-introduction. To be patient-centered, greet them warmly, let them know your name and preferred pronouns, and tell the patient what you're there to do.
Also, your title. Tell them what you are. Hi, good morning. My name is Nelson. I'm your medical assistant today, and I'm here to take blood. Dr. Castaner ordered some blood. Have you taken blood before? That's typically my canned, way I introduce. Because do you also see that what you're there to do? Because if your patient starts rolling up their sleeve or they nod their head, you now have informed consent. You now inform the patient exactly the procedure, what you're going to do. Because and your patient acknowledged your presence as a medical professional. Therefore, now you're legally cleared to touch the patient.
Hi, Elena.
Hi.
Hi, my name is Stephen. I use he, him pronouns, and I'm here to draw your blood.
Great.
How are you doing today?
Oh, not too bad.
Fantastic.
Step number two is verify. Verify that you have the right lab order for the right patient by having the patient state their full name and date of birth, and then confirming this on the lab order.
Now, our protocols go one step further. The two things because not only their full name, but the two numeric identifiers that you have to confirm. If you're in a hospital setting, it's date of birth and the last four digits of the social security number. If that thing flashes one more time, I really wouldn't care less. I'm Asian. I really wouldn't care less if it's Asian American Day tomorrow. All right. That being said, okay, so for our purposes, it's full name, date of birth, last four digits of your social.
Well, before we go further, I'd like to verify that I have the right order. Could you please verify your full name and date of birth, please?
Yeah, Elena Satter, 7/30/88.
Fantastic. That's what I have here.
Step number three is cleanse. Don gloves and clean the surface that the patient's arm will be resting on with a disinfectant wipe.
Now, this is typically done before the patient comes in. Or here's a trick that I used to do. I just take this, the paper, and just roll it over.
Not too bad.
Okay, great.
I also remove and dispose of my gloves and wipe at this time. And then I use hand sanitizer in front of Elena so she knows that my hands are clean.
That I don't understand because I just keep my gloves on.
Do you have an arm preference?
Usually I think this one.
Okay, fantastic.
Because right here is where different COVID protocols change. In the Commonwealth and in the district, it's glove. Everyone gets gloved up. But and also you could also see on the video he had ink and he's got his wedding band on. there's these little things. Here's also the neat thing. He has his ID badge clearly visible with his name and title. And we'll be doing, and this is the hardest part.
The next stage
finding
of the
the vein.
procedure is to tie the tourniquet. Tying a tourniquet widens the superficial veins in the antecubital space. This makes locating veins easier, which helps make the draw easier. Tourniquets should be tied approximately 3 to 4 inches or about 4 fingers width above.
And another number that's really common on the AMT, RMA exams and the CCMA exam for NHA, 5 centimeters, but 4 fingers width, 3 to 4, because it's weird because 4 fingers width is about 5 centimeters, but 3 to 4 inches is like, I don't know, like 8 fingers. But I've seen the number 5 centimeters more than I've seen 3 to 4 inches. Just make sure that this is your antecubital fossa right here. Make sure it's tying your tourniquet is well above that, because we're going to look for these 3 veins. Where's my... That area or that depression is called your antecubital fossa. And in your antecubital fossa, you have this. So what are the veins that we're looking for, right? The main one is your median cubital. And it's the one that's going to come, it's here, and it sometimes comes down a little bit here like that into your, but it's like the main one that's in the dead middle of your antecubital fossa. Now, the other one here, right, that's on your thumb side is your cephalic. It branches off like this and goes into here like that. And the other one that's on your pinky side, that's your basilic vein. These are the 3 veins that I'm going to need for you to be able to identify. Here's a little bit clearer one. So you have the median cubital, you have your basilic here on the side, and your cephalic here. And the cephalic is thumb side, the basilic is pinky side, and of course median means median, all here in the antecubital fossa. That's a lovely question. I've seen it on when I took the NHA, and I've seen it on both the RMA and the NHA CCMA prep for medical assistant registry. So, and you know, it's a nice tie-in for your anatomy and physiology, all in this area called the antecubital fossa or depression right there.
Crux of the elbow. The tourniquet should be tied flat. Avoid rolling the tourniquet since this can be painful for the patient. Place the tourniquet behind the upper arm, grasping on either side, and pull to the front and cross into an X. Pinch the front connection with one hand and pull it slightly away from the skin.
Now, the one that you pull on to make tight, like when you make the cross, it's the one in the front. You pull up and then you tuck. And when you tuck, you notice, and I call them rabbit ears. The rabbit ears will end up on this side of the arm, so it won't get in the way of your antecubital fossa. Another thing to note that this is colored blue since it's non-latex, okay? So if it's not colored blue, check the box that it came in to see if it's non-latex, because latex allergies are quite common, okay?
Use your other hand to tuck the outer fold under the connection.
And all of this, when we're in lab, you should be able to do with your gloves.
Pinching and securing the tourniquet. The small loop allows for an effortless and very stable and still release of the tourniquet.
See how the rabbit ears? See how the rabbit ears are on the outside? And the thing that you tucked, see this thing? That's the thing you tucked in. That's the thing you're going to pull when you want it to release.
Patient's arm. The tourniquet should be snug.
Oh, I forgot also this. The longest you can keep this on is 60 seconds or 1 minute. Yet again, another common question on the registry for phlebotomy exam, the RPT. And the reason why you don't want this on here for more than a minute is the blood starts backing up and you're going to have what they call hemoconcentration. The red blood cells are going to be abnormally increased in your sample, and that will have a false positive for a red blood cell disorder. Okay, so no more than 1 minute, and we don't want hemoconcentration and non-latex.
Just tight enough to compress the veins, but not uncomfortable. Asking the patient is a good tip here. The ends of the tourniquet should hang out of the way, and you need to know which end to pull in order to release it. Once tied, do not allow the tourniquet to be tied for longer than 60 seconds because it's uncomfortable for the patient and can cause inaccurate readings in samples.
And again, that's hemoconcentration.
Next, I want to discuss how to select the most appropriate vein for the draw. The inner elbow area is called the anacubital space, which is where larger veins are near to the surface and can be most easily accessed. In selecting a vein for the draw, you should follow this order of vein preference. The most preferred vein is the median cubital vein. This vein is located in the middle of the anacubital space and is often the vein that is seen and felt most easily. If the median cubital vein seems difficult to locate, then the second preferred vein is the cephalic vein. The cephalic vein is the outermost vein and is seen best with the patient's palm facing down. If neither the median cubital nor cephalic vein seems suitable, the third vein in the order of preference is the basilic vein.
And that's pinky side.
The basilic vein is the innermost vein and lies just above the brachial artery. It is a safe choice after you have become comfortable with the procedure.
Now, you'll be going superficially into the skin, and you're not going to rely on your eyes. You're going to rely on your touch. You're going to look for something right underneath the skin that kind of feels like spaghetti, like really, really mushy spaghetti. And that's the tube that you're looking for. And if you have a tourniquet at home or maybe something to clamp off one of your family members, try a male, non-obese young person, 25 to 35 years of age, and then you'll see their veins sticking out. I want you to feel around the antecubital fossa at home and kind of like close your eyes. Don't really look for it with your eyes. Look for it with your feeling. And that's the skill set, the hardest part of this skill set, because once you identified the vein, everything else is downhill from there.
Many veins will be difficult to see, but you can locate them by feel using palpation techniques. These techniques will take some practice. I'm using 2 palpation techniques here, one after the other. You should notice that I'm first pushing down on the vein and then gently releasing it. And then I'm pushing and pulling the vein from side to side. When I push down on a vein, I'm stopping the flow of blood. And then when I release it, I can feel the vein become larger as blood refills it.
And then you could like kind of stroke it.
Pulling side to side technique allows me to feel.
This is what I do. I kind of like take my fingers like that, and then I like lightly stroke, right? Now, another thing you'll see other phlebotomists do is like tap the arm. I found no academic data or medical data that says that works, but it just works. I don't know why. Another thing also that works, which I can't find any data on, I've just been doing since I was in EMS. I just wipe this area real quick with alcohol, the 70% isopropyl alcohol, and for whatever reason, the veins seem to pop, especially for, like this young lady here. She's kind of petite, and also children and, people like me. When you're in lab, well, you guys aren't allowed to touch each other anymore because of COVID, but I can kind of show you my horrible veins when we're in lab. Before I was actually your final exam regarding phlebotomy, but again, due to COVID, we're not allowed to do that kind of thing anymore.
Vein as it resists the pressure of my finger. You'll notice that I'm using these techniques on all 3 veins in the anacubital space. At this point, I'm also determining the direction of the vein, which brings us to the 3 Ds of vein assessment. The first D of vein assessment is depth. How deep is the vein? Visualize how deep
And it
to put
shouldn't
the
be that
needle's
deep.
opening in order to meet the vein in the middle. The second D is diameter. How wide is the vein? Identifying an entry point in the center of that width. And the third D is direction. Which way is the vein traveling? Align the needle in the same direction.
All right, and palm back up.
After I've selected the best vein, I let Elena know and ask for her verbal consent. I then release the tourniquet.
That's perfect. Would it be?
See, because I don't like that. You're already poking the patient. You're already touching the patient. The consent should have happened way before I started touching you.
We went right here?
Sure.
Okay. Release your tourniquet.
Now I'm about ready.
Now, I don't agree with releasing the tourniquet because if I'm a pro, I can assess this in seconds and I have a whole minute. Think about it. A minute is a long time. 1 Mississippi, 2 Mississippi, 3 Mississippi. It's a long time in the clinical world, 1 minute. So I already set this up. So why would I take it apart? That's just my 2 cents.
The draw, and I just need to cleanse the draw site on Elena's arm before staging the supplies. To cleanse the draw site, I'm using a 70% isopropyl alcohol wipe.
And I'm going to wash the site.
And remember that that's
This might be a
common.
little cold.
I'm starting at the center and then circling outward.
Now,
Next, I
the
stage
way you
my
swab it, let's say this is the middle of our house. You start in the middle and then you do concentric circles, getting larger and larger. You never go over the same real estate twice. And there, he did it very superficially. I like going all the way almost to the sides of the arms because some patients, their cephalic and basilic veins are like mine. They're all the way on the side, right? So, and back to, he was talking about the 3Ds. Find your positioning and find the direction of the vein. So if the vein's going this way, I should move my patient's arm so I can have better access.
supplies. I'll need a multi-sample straight needle, a tube holder, cotton, and the required tubes. Keeping the needle cap on, I assembled the needle and tube holder. I'm planning to hold the needle in my right hand, and so I'm putting it next to Elena's arm on my right-hand side. I place the cotton and tubes on the opposite side.
Now, this is important. If you're right-handed and you're going to stick this way, all your gear should be onto the left so that you avoid crossover. Because you crossover, you can easily bump into the needle. You could poke her by accident. You could poke yourself by accident.
My left side, since this hand will be free during the draw. I then don well-fitted, clean gloves. Now I'm ready to perform the blood draw. I check with Elena to be sure the alcohol on the site has dried before retying the tourniquet.
Now, that's an important question. Why do you wait until this is dry? And don't waft it like move your, you know how they like fan it with your hand? Don't blow on it, right? I've seen that in a clinical setting. Let it dry naturally. Now, a common question on the RPT exam is, why do you let this dry? The 70% isopropyl alcohol dry. Because if you don't let it dry and it stays wet, when you stick the needle in, it's going to cause hemolysis. And also it's going to hurt, right? You know, because it's isopropyl alcohol, right? So that alcohol, that little bit, is going to get into the needle and it's going to start lysing some blood. And then the lab will pick it up as a false positive for hemolysis. Hemo, blood, lysis breakdown. And that's not a good thing, okay? So let this dry, let it dry naturally. Now, while that's drying, that's when, you know, you do talk, how's them Yankees, yada, 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 right? And you're prepping and you're doing all these other things, right? But what I like doing, especially if the patient's nervous, I like having the patient focus on something else. And talking to them is another way that they can focus on this quite scary procedure that's about to happen.
with her about the tightness and comfort of the tourniquet before I continue. All right, does that feel dry?
It does.
Okay. Retie the tourniquet. Perfect. Does that feel okay?
Yeah.
Okay. I now uncap the needle and inspect the bevel for any burrs or damage. From this moment on, I'm being very careful to maintain constant positive control of the needle. I need to be aware of the position of the tip of the needle at all times throughout the procedure and until I've closed the needle safety guard after the draw. Now with my other hand, I place my thumb on Elena's forearm, well below but in line with the intended vein. I press gently down and away to anchor the vein.
Now, your dominant hand that's going to stick, this is called the anchor. Once this needle goes in, the needle should go bevel up at 15 degrees. Those are common RPT AMA questions. It goes, and this is called the anchor. So this stays put after this needle goes in.
With the needle bevel up, I now lower the needle to the arm in line with the intended vein at a 15 to 30 degree angle. The back of my fingers are keeping a gentle weight on Elena's forearm for stability and flexibility.
Now, the good thing about the anchor is that you can feel when your patient's about to jump. And with enough pressure, you can actually keep the patient's arm down.
I now make a quick and smooth insertion. Stop.
Don't go slow. It hurts. So you make the commitment. Once you know where the vein is, boom, you go. And do you see the depth at which the needle went in? He didn't put it all the way into the hub here. It's about, a third or halfway in because this vein is very superficial.
At the point where I think the opening of the needle is in the middle of her vein. While looking at the needle, I pick up the first tube in the order of draw.
Now, we're going to talk about these color top tubes later on in today's lecture. They have to go in a specific order. And sometimes and you've heard him call it the multi-stick needle. This is a multi-stick needle because you can do multiple tubes.
Using the flange on the side of the tube holder.
Remember, this is the anchor. This doesn't move.
Press on the tube, being careful not to adjust needle depth in Elena's arm. Doing okay?
Yeah.
In the correct position, blood will be drawn into the tube. And you'll see that I've been successful here. Remember.
Now, if blood doesn't immediately go in, it's called fishing. It's a more advanced thing, so be careful. You move the needle out a millimeter, and you move it to the left a millimeter, and move it to the right a little bit, and then you could do what he also did. You twist the vacutainer, but you could see now, then the blood immediately goes in.
Only minimal
you let the blood
or straight
fill.
Out adjustments are
It won't overfill.
Once the first tube is full, I remove it and invert it 2 or 3 times before placing the next tube.
Actually, let's stop. That's not the proper way to invert it. That could pop out of his hands. And even though this is, it's like hard plastic, we don't use glass anymore. If that thing falls on the ground, you can't use that sample. That's why there's different methods, and I could show you that in lab, how to properly cradle this so that it doesn't fall on the ground. Because if you just use the tips of your fingers like this, especially if your hands are wet or you're moving fast, it's going to fall.
When the last tube begins to fill, in this case, the second tube, it's then that I release.
This is also a difference of opinion. I find that once blood starts going out, even on the first tube, I let go of the tourniquet already so that the procedure can be faster.
Tourniquet. When this last tube is full, I remove it and invert it 2 or 3 times.
And that too, sometimes they say 5 or 6 or 8 times.
With
now,
my free hand,
you're mixing
pick up the cotton and hover over
You're mixing it so that the chemicals inside the tube get the mix, because the chemicals inside these tubes are anticoagulants. And when we talk about the color top tubes, you will need to know the names of those anticoagulants.
Site. I quickly remove the needle at the same angle as I inserted it and immediately push down on the site with cotton.
And you could now see why I don't like just loose cotton. I like the, the prepackaged gauze, because I don't know where this cotton's been.
At the same time, I activate the needle safety guard on a hard surface nearby, and you'll hear the click of it.
Now, do you see how, well, what I like doing is I like having the patient hold this down so I can do stuff, because this has to be down for at least 1 minute. And the protocol states that you move away, like I try to click it someplace where it's safe and out of the way. You'll see some bad habits. Sometimes they do it on their hand, or they do it on their finger, or they do it on the side of their scrubs. Please don't do that. I saw that twice. Last time I was in the hospital with my wife, I'm looking at the tech like, did you have to do it that way? And she was like, and she smiled because she knows that it's a bad habit. But she was good though. Everything else was fine.
Can you hold pressure for me? Sure. Thank you very much.
While Elena keeps constant pressure on the site with cotton.
Now, having these things that are circular and they can roll around, you'll see in our laboratory, we have like test tube holders. That's a better way to do things. Because how many times I was in the ER or I was in the ambulance and this stuff started rolling around? Kind of scary.
Finish the tube inversions. Most samples need 8 to 10 inversions in total. Remember to be gentle. I label the tubes in front of Elena. Labels typically include the patient's full name and date of birth.
Now, if you have a printer, some facilities, especially the hospital, has a full printer. But again, you'll probably be pressed for time in a mom and pop office. So have that barcode in there. And I quickly put the patient's name, like last name and date of birth on them with a permanent marker, just real quick. But most of the time, I usually don't have time. The barcode. And when you have the paperwork nearby, you just slip that all in there. And the last sheet, which is, I believe, pink, I can't remember. That's the one you keep for your facility. And again, that's if they have a paper system. A lot of facilities now have electronic medical records, which they have a mini printer, and they'll print all of this stuff out onto the label.
Date and time of collection, the phlebotomist's name and credentials, and any other information required by the receiving lab or per clinic protocol.
So this is what you're doing in that 1 minute while she's holding this.
You take another look at the site?
Now, after 1 minute, you check to see if there's any more bleeding.
Next, I recheck the site to make sure bleeding has stopped. I put on fresh cotton with...
Now, if it didn't stop, keep the original cotton on there. That's an RPT AMA question. You don't remove the cotton, because if you remove the cotton, it's like the bleeding process will start all over again because it has a platelet plug on that cotton already. So leave the original, even if it's blood soaked, and then you put more gauze on top. Now, if they're still bleeding after 1 minute, you have the patient hold it down, raise their arm above the level of their heart for another minute. Then you recheck. If even after 1 more minute, you recheck and it's still bleeding, just have the patient hold it down, make sure you document it, and then inform your chain of command on what to do. And it's a rarity, but it happens every once in a while.
But not before checking for tape allergies or preferences with Elena.
Are you okay with tape?
Yeah.
Now that Elena's part in this is done, I excuse her and thank her. She did all the hard work since she's the one that got poked.
Thank you very much, Elena. You were great. Have a wonderful day, and we'll get a hold of you as soon as we get those test results in, okay?
Great, thank you.
Have a wonderful day.
With gloves still on, I cleanse the entire area with disinfectant wipes and then prepare the specimens for processing. Once the specimens have been processed, I remove my gloves, wash my hands with soap and warm water, and then we'll return to my workstation to document the procedure in the patient's medical record. Now that we've gone step by step through the procedure, let's watch it without interruption.
All right, so that's the entire process. Any questions on that? And we're going to be practicing that not next week, but the week after. Any questions?
No.
No, we're good. Now,
We're good.
let me show you. Yes, question?
No, I said I'm good.
Now, let me show you the other two techniques. And butterfly is also called winged infusion, okay? And it's the same thing, but it's a little bit trickier because you could see that there's like more paraphernalia to be utilized. Let's see. Let's pick one that's new. Why does this not look? Oh, good. I know Ruth McCall's book, so let's use it. So the difference between this is now the Vacutainer is the classic. Actually, that's the one that you should have the skill set for. That's the one that offices. My second medical assisting job, this is how I was interviewed. I showed up to the interview. The office was swamped, and the physician goes, she asked me like, hey, you know how to do venipuncture? And I go, yeah. He goes, can you help me out? And it was a trick. It was actually my interview. She goes, can you help me out? And he goes, I'm a little bit swamped. Can you, her and her office manager like stood aside and goes, can you do these three people? And it was a family. So it was like the grandfather, the father, and a little kid. And actually they were timing me and they wanted to see the rapport that I can develop from being a stranger just off the street. So I was in my suit. I put on my PPE and I did it and I went through the entire procedure just like the video. Guess what? I did a butterfly on the older gentleman on his hand because butterflies are used for if you need greater control and if you need a smaller gauge. But nowadays, butterflies are expensive. That's why vacutainers are much, much better to use. And also butterflies, in my opinion, such a small needle, it doesn't take too much skill, in my opinion. The Vacutainer, that's the skill set. But I did Vacutainer on the older gentleman because he required a little greater control. I also used Vacutainer on the baby. It wasn't a baby. He was like 4 or 5 years old. And then on the father, who was in his mid-30s, I used the normal Vacutainer. I did the procedure just as you saw in that video. And after she was done, you know what she said to me? He goes, help me get through this rush. He goes, and I'll pay you double time for today. And I was her MA for the next 2 years. And I eventually became her office manager. So you don't know how you are to be assessed. So if you've got skill sets, so right there, I thought that was a beautiful way to assess me because she could see how I developed rapport with a perfect stranger, to see if I knew my aseptic technique, and to see if I can get the blood and then process it all. And I did it all in, I don't know, 6-7 minutes, back to back to back. And then she looked at me and goes, help me out with the rest of these patients. And then I'll pay you double time today. I looked at her, I'm like, yeah, sure. And back then I was getting, this is like early 1990s money. I was getting $11 an hour. And that was a lot for an MA back then. Skill practice, butterfly draw.
Our proven installation process ensures your gutters are in tip-top shape and
My
prep to
gutters
protect
are
your
fine.
home. Step 1, we clean.
All right. Let's see if this one.
All right, welcome back to Phlebotomy Solutions. I want to go ahead and make a comment that I didn't make in my last video for the straight needle.
So let's just jump right through the procedure.
Just like the tourniquet.
Now, do you notice also that he set up the stuff that he's going to stick because it looks like he is right-handed, and then all the other material, the gauze, isopropyl alcohol, all the other things here. Now, since it's such a small needle, we already checked all the veins here and here on the volar surface, and we have a no-go. So we need to get the smaller veins here. And the better thing for control is this setup here, and it's with this is called a lure adapter. So it has the tube here and then the needle here for the Vacutainer system. And it has, of course, the butterfly, also known as winged infusion kit or set.
Left on longer than 1 minute. So the same effect.
Let's get to the
Let's talk about the back of the hand and drawing from the back of the hand, which veins and how we do this. As far as steps and procedures go, nothing changes except for one thing. The veins, there's no order of veins here. As we had above in the up at the break of the elbow, the Anacubital Fossa area, we had the median cubital, the cephalic, and the basilic vein. Here, we just have the dorsal metacarpal veins, and they go from the knuckle up to the wrist area where the watch would go. And there's no specific order on this. We can draw anywhere between the wrist above where the watch is or at the watch area down to the knuckle.
You just look for the juiciest
draw on the
one.
Inside of the wrist where the radial artery is or anywhere along the knuckles. Those are off limits. CLSI standards only allows us to draw
I forgot to mention
here
that.
at the dorsal.
The people who give these standards is this quasi-government agency called CLSI, Clinical Laboratory Standards Incorporated or something like that. Everyone just calls it CLSI. And CLSI, they're the ones who collect the data and along with OSHA, monitor our laboratory safety with respect to anything needles and anything biohazard.
Area and the wrist area. These veins come from the basilic and median cube and the cephalic vein interchanging on the outside coming in. So between the cephalic and the basilic, they run in and interchange, connect, and form the dorsal metacarpal veins. Now, so again, we don't have an order here. So with this, we say off of, like I said, the knuckles and inside the wrist. The equipment is the same, is different as far as the device, of course, the butterfly, not a straight needle, but as far as the one end having a rubber sleeve with a needle in there for the adapter, that's the same, like a straight needle, except now we have a tubing and we have
that adapter is called a lure adapter, LEUR.
Standard draw for a butterfly needle on the back of the hand is 23 gauge. You'll see it says 23 gauge here. We don't want to use a 21 gauge in the back of the hand.
Now, 23 is not even that small. I use 25s on pediatrics. That's the original. 25s were the original number. Now, you see, not all companies put the number. You'll see this is light blue, and light blue corresponds with the 23 gauge. And what's gauge? The gauge is the lumen or the hole, the size of the hole of the needle. And the bigger the number, right, the smaller the gauge or the smaller the hole of the needle. So a 25 gauge is tiny, right? And a 23 gauge is a little bit less. And let's look at the gauges. Needle gauge color. So if you see like a needle that has a cap that's green, it's 18, pink, 20, blue, 22, and that light blue is like 23. There's a whole, here's the whole set, and you could look it up. But the more common ones are the greens, they're 18, and I thought it was light blue, but the 20, I use 25s and 23s, right? But the green is very, very common for adult. Okay. Now pause a little bit here for some of these common colors. So, and the gauge is just the tippy tip on how big the hole or the diameter of the hole, and the length is a different number. So if you look at this, these are different lengths. Okay, this is about 1 inch, and this is a 1.5. Right.
Typically, because the needle is too big and it can collapse the vein, it's a little more painful for the patient, and it's just not necessary. So a 23 gauge is perfectly fine. If I want to use a 21 gauge butterfly, I would use it where we did the straight needle at, and I would draw there in that area of the break of the elbow.
And having a 21 gauge butterfly, that's cheating. You know, but nowadays we have all sorts of butterfly sizes nowadays.
So I want to reserve my 21 gauge. So when I do the median cubital or cephalic vein at the break of the elbow. Okay. So the anacubital fossa where all three veins lie at the wrist areas where I want to use my 21 gauge. Here, I use the dorsal metacarpal veins. So again, same type of equipment, just more of a butterfly.
Ooh, running out of battery.
And of course, my tubes, my tourniquet, my alcohol, and of course, my 2x2s here. So again, we always look at 3 to 4 inches above the site for my tourniquet. So I'm going to tie my tourniquet the same way.
What's with inches? It's 5 centimeters.
No order of the vein, so I don't have to worry about searching for one. I just look at the same one I have. Here's my tourniquet tied.
So it's
now,
the
again,
same
I wanna
procedure,
look
but
here,
different
kind of
equipment.
find the best vein that I can find. What I'm looking for is a vein that's not too big, not too large and fat, because those can collapse a little easier. But I'm also going to look for a nice sturdy vein. Here's the other thing. If I'm dealing with a neonate or an infant, I'm using a butterfly, whether on the hand or even on the break of the elbow. I don't want to use large tubes. These are adult-sized tubes. The vacuum is stronger, and if I use these on a neonate, it takes too much blood out on an infant, and that can cause some serious problems. I have a video on this.
Well, actually, what it does is, again, causes hemolysis, hemolysis. The blood, it's like, the best way to explain it is that it's like, let's say we have a whole room of people and we have a tiny little door and everyone starts rushing for that door. A whole bunch of red blood cells are going to get destroyed. So you don't want on an infant, you don't want to use a full size tube. You use these things called microtubes, but that's for further pediatric training. But that might come out maybe on exam. I've seen like if you use a gauge needle that's way too small with a full set of a full adult Vacutainer tube.
Dealing with blood cultures and of course finger sticks, capillary sticks on infants, heel sticks, and I give a chart on how much blood we're allowed to take out. But we have tubes that are a quarter of this size for children, basically 8 years, 7 years and under. And we want to make sure we use those tubes if we're dealing with infants or newborns, not large tubes like this with vacuum. So keep that in mind. These are for adults, and we want to make sure we keep them for adults. So again, the assembly of the equipment is always the same. Again, I take my sheet off of here and I get my Vacutainer holder and I attach it the same way, screw it in, and I'm ready to go. It's simple and it's easy. This does have a plastic sheet over the needle, so when I'm ready to take it out, I have it, no problem. So once my equipment's ready, my tourniquet's on. Again, I fold up in quarters, work for the center out. If I'm locating my vein right here, I go 3 to 4 times center out. I do not rub over the site. We discussed that earlier in a straight needle draw. That's a no-no. So again, take my butterfly here. There's different ways to do this now. People have asked me, how do you handle this Vacutainer holder? Couple of ways. I can either hold on to it with this hand, pop my needle in. If I'm able to let go, then I can let it go and get my tubes and go in and out through here. Or I can actually put it in this hand here, grab it with my 2 fingers, go here and here. I don't like to use the wings of this butterfly. I don't like to do this, and I tell you why. When you use a butterfly and you get into a vein, you'll see a flash of blood right here, and that tells you you're in the vein.
Now, that's called the dead space. And do you see how the butterfly wings are like, they're on the bottom? That's how you also know you're holding it correctly to have your needle will be bevel up. Here's what we mean by bevel up. See, this is bevel up. If you look at a needle, it's not really, it's like a triangle, and the hole has to be up, because if you go this way, right, bevel up, see this blood vessel, then the blood will easily scoop right in. Now, if you go bevel down, you see how if the blood's flowing this way, it's harder for the blood to go in. So that's what they mean by bevel up. And also, I kind of semi-agree with his assessment that this thing's called a dead space. But if blood goes here in the dead space, I'm telling you, it's going to go through this tube as well. So you're going to see it. So you're going to see blood. If you hit the right vein, it's going to go, this thing's going to be red. This is going to be red. And then you're going to see blood start going into this tube right here, even when you don't have the Vacutainer system already plugged in. And also my variation is I like putting the needle here, right? I move these things out of the way and put the needle around here. So it frees up my other hand.
If I am holding on to the butterfly like this, I can't see the flash. So for me, I like to use my 2 fingers and a thumb towards the back here, enough so I can see the flash. So when I'm in, I stop, just like I did with the straight needle. I hold here, in, stop, and now I can go ahead and do this. Get my tubes and go in. I could also leave my tube already in here, just not all the way in, just like this. And when I'm ready, I can just pop it in. But again, I hold 2 fingers and a thumb.
Now that method of like holding the tube in with like 3 fingers, I don't like that. I'll show you a way to cup it the way they taught me when I was in EMS.
And go right in through here. So if I'm going to draw, I like to go from right here at the side. Here's the vein. I don't like to go directly in the vein because veins move. And if this vein moves, if I go in, that means I'm going to have to redirect my needle and start to fish in order to stick my needle in the vein.
Yeah, we don't like fishing
and again,
too much.
There's no fishing. What I like to do
I don't
is I like to come at the side of the vein right here, just centimeters before the vein, go into the skin, push the vein through and pop it in. If the vein moves, that's okay. I can just keep moving forward until the needle pushes into the vein. So I don't go directly in. I come at the side and go in. Remember, no fishing. This is a scalpel.
Right. Well, I'm from the school that sometimes you got to go fish. But me, I goes, yeah, because if you go in the line this way, it's going to poke through the other side. But do you see how like the majority of this goes this way? So I like his idea going sideways, but I like it going sideways here. So let's say I kind of miss, it's going to eventually hit the inside of the vein here. Because this way, if you go sideways, it might go through. See this angle here? And then you're going to get a hematoma. Now, hematoma is the #1 most common side effect. It doesn't mean that the technician did it wrong. I repeat, it does not mean that the technician did it wrong. It just means that your vein is starting to leak out blood into the third space and it's going to puff up and sometimes it's painful. And we're going to talk about how we deal with that as well.
Little micro scalpel. If I start to move it around like I did, like I told you earlier on the straight needle, it can cut. You can lacerate the vein. If I was doing it up there at the break of the elbow, I can lacerate a nerve. I can hit a tendon.
Well, because just know that when you do fishing, you don't move a lot. It's millimeters. But I'll show you that in lab. And in theory, novice phlebotomists shouldn't go fishing. Shouldn't go moving the needle around to try to find the vein.
You know, I could, hit the artery. I don't want to do that. It's very painful and you don't know what damage you're doing underneath the skin. So no fishing. Once I go in, then of course I can let it go. If I'm able to, that's fine. Get my tubes, pop them in, pull them out, invert, set them down, get my tube, pop them in, set them down. All right. One thing I wanted to mention that I forgot.
Now, if you don't get blood, you take the tourniquet off and then you go through the rest of the procedure. Right. But once you see that blood going into the dead space, right, you let the tourniquet go and then you follow the procedure just like the previous video.
I mentioned the video was how we anchor or retract the skin. Now, before I go in the needle into the vein here, I want to be able to hold the hand here with my thumb underneath the hand with my fingers on the thumb and just retract and pull down at the knuckle, draw back and pull down as the needle is about to go in. So my anchoring and retraction here is push down, squeeze, and pull down on the hand. I could have them relax their hand underneath my fingers here, use my thumb at the knuckle, and then pull down and retract and anchor the.
And that's why I like having my non-dominant hand free, and I put the barrel over here because I like doing this. I always like anchoring because remember what he stated, which is true. veins are superficial and they squirm around a lot. So anchoring it down here and keeping the skin taut. Now, I don't like when the patient makes a fist because it tenses all of this stuff up. I need it semi-loose, right? And also, the more tense your patient is, the more likely they're going to jump. So keep the hand relaxed, right, in that position, and then, you can anchor it this way. All right. Now we've seen two procedures. The last procedure is for patients who have what they call crenated veins, Crenated. Crenation is when typically with a geriatric patient, we stick the needle in and then the entire pressure is so low in the vein that the vein bottoms out. And that's what it's called, crenation. It like shrinks, it shrinks away. And that's not good. So, and that usually comes from using a Vacutainer system such as these two systems utilize. So we got to use a syringe, and a syringe is the best way to control. Let me just show you at least a brief picture of it. This is the third method. And now you see we use that with geriatric patient, and you can see here, the same exact method, you anchor, but then you're non-dominant. That's the one that draws on it. And it's the same technique. And when we're in lab, we're going to practice all of three techniques in laboratory. Now, where are we? So if we look at the actual procedure, it's the same thing that video goes over. And you could see here, if we were in, like before the labs, we used to do this like every day. But again, COVID, can't be in lab and all that stuff. That's what I really miss, coming into lab and you guys totally getting your time in and practicing. But you could see here, if you look at the rubric, it goes over the same thing that the video does. So if we were doing an exam, let's say you missed, or you missed explaining the procedure and missed confirmation of the pretest instructions. Well, out of the possible 10 points, I might only give you 8 or 7, stuff like that. I actually greet the patient, confirm. I actually put way more points in here. And what I like doing on exams is that, us for this class, we're just going to practice, but we're going to go over a mock exam to see how it feels. Everyone starts off with a 100, and every time you make a boo-boo, you start taking points off. And then at the very, very end, we calculate what you got left. Okay. And the acceptable score, according to our rules, is a score of 85 and above. And when we clear you, that's what the score on all the rubrics must be before I set you free in internship. So let's now look. So that's the procedure, and that's what we've been watching for the last, 40 minutes or so, 45 minutes or so. Now look at this thing, the color top tubes. That, go home and when you go study, if it opens, hello, okay. That has a whole list of all the tubes and their additive. So you need to know the additive. And you don't need to know this big name here. Just know that if it's a lavender top tube, it's not purple, they call it lavender. The additive is an anticoagulant called EDTA. And what are the common tests? CBC. CBC is the hematologic test, known as your CBC, is the most common test. So that's what you need to know on each tube. What's inside it and what is the common test? Light blue, it's all of the tubes that we're going to mention that have something in it have anticoagulant as their substance. So for light top tubes, right, or light blue, sodium citrate, and sodium citrate is your PT-PTT, which is a coagulation test. That's your prothrombin time, partial thromboblastin time, INR, which is your international normalized ratio. So you'll see it as PT, PTT, INR. That means I want to see how you're bleeding. And it's called a bleeding study or a coag study. And that's your light blue top, sodium citrate. Green tops, sodium heparin. Most common, chemistries and ammonia. So chemistries are like sodium, potassium, and all these tests, sometimes they're called a Chem 7, Chem 12, Chem 23, and the number right after it means that the type of chemistry tests that we're doing, and they almost always include glucose. So if I'm doing a chemistry or a SMAC, SMAC, which is also another acronym for chemistries. I forgot SMAC was serialized something, something, something. I forgot that. You know what? Why am I sitting here not telling you what it is? Like SMAC 20, it's a blood test and it has 20 tests. And the last test is glucose. And SMAC stands for, here, sequential multi-channel analysis with computer, right? Which means just what? Chemistries, right? And a SMAC 20 has 20 tests, and the 20th test is glucose. If you have a Chem 7 or an SMA 7, it's what? It's Chem 7, and goes, it's for chemistries. And one of the more common tubes that we're going to use for chemistry is your green top. If you're just doing glucose, it's a gray top. Okay, and its additive is sodium fluoride. Red, gray, speckled top, also known as a tiger, right? You know, it looks like camouflage, and also might have an SST tube in it. What does SST look like? Looks like this. Now, SST tube doesn't have any additive, but what does it have in it? You see here, it has that little plastic thing on the bottom. It either could be tiger top or mottled. They call it mottled top. So it looks like, you know, like this, like gray and red. It could be gold or it could be just red. Now, no matter what it is, none of these tubes have any additive in it, but it has this serum separator plastic thing in here, because when we spin that thing down, it helps us get all the layers. It helps us separate the blood into your serum, your buffy coat here, and your red blood cells. And I wish we could really poke somebody in lab, because pre-COVID, we used to get your blood and then we used to analyze it. We used to do all these fun things. But when we're in lab, we're only going to do the procedure and then we're going to skedaddle. So no one wants to be a point source of infection. Let's see now. Red top tube, no additive. Again, SST tube, no additive, but it has the little little plastic thing in it. Red top, no additive. And what do we use red tops for? Just like the green, we can use them for chemistries, especially glucose, cholesterol, triglyceride. So the red top tube, very common. The lavender, the first one I talked about for the CBC, very common. Yellow top, that has SPS in it, and that's for blood culture. Now, what's a blood culture? I want to grow whatever bacteria is in my blood, so I know to see what specific infection is inside my blood, and that's a yellow top. Light green, not as common. Nice to know. Orange, not as common. It's for stats. Royal blue, it has EDTA in it, and we use it for tox screen. Now, what's the tox screen? Toxicology, Logi, study of toxins. So if I want to see if someone has drugs in their system, and the typical drugs, you know. Tan is EDTA, and it has EDTA in it, and we test it for lead. White, not too common. Pink has EDTA, and we use that for hematologies, like for type and cross. So if I need to know your blood type and cross match, I use pink top tubes, also known as your hematology tubes. And red and gray, not an important thing. Okay, so those are your color top tubes. So how could I ask this on an exam? Hey, what's inside a lavender tube? And you'll tell me EDTA. What is EDTA? Oh, it's an anticoagulant. What's any of these chemicals. They're all anticoagulants. We don't want the blood to clot. And if we don't want it to clot, that's when we do this thing that we were showing you, how to mix the blood in the tube. This is how you do figure eights. They're not going to show it. All right. Let's see. Where's my webcam? Okay. Can you see my webcam?
Yes.
So let's say this is a tube, right? Now the guy was doing it like this. Do you see how flimsy this is? If I do it like this, right?
Yeah.
What could happen? So when you have the tube, of course, gloved hand, you cradle it. You don't grip it, but you cradle it. And then you do something called figure eights. See how I'm doing this? Like an 8. And I do that 5 to 6 times, 7 to 8 times, depending what textbook. And that's how you do it. And then I take it and I physically place.
Yeah.
I like placing the tube holder thing. All right. So that's what a figure 8 is. And anything that has any anticoagulant in it, it has a figure 8. So I could ask you, lavender top tube, do we do figure 8s? You say yes. Light blue top has sodium citrate in it? Yes. Green top tube, it has sodium heparin in it, and it goes yes. But if I come down here to my model top or my speckle top SST, it doesn't have anything in it. So you do not do any that and the red top plain tubes. These 2 tubes, you do not do figure 8s. You actually be gentle with it and you put it upright. It goes on a tube holder because I want this thing to clot. And I'm going to put it in a centrifuge and I'm going to make sure that all the red blood cells go to the bottom. And then what am I left with? Serum. And then in serum, I could look at a whole bunch of things like chemistries. And in here, glucose, cholesterol, triglycerides, high density lipoprotein, potassium, amylase, alkaline phosphatase or ALK-Phos. This is for, but just know these are all chemistry tests. And also anything that has to do with serum. So any antibodies. So that's what? Red top tube. And I could also do that with my gray, gold, or tiger for SST. And it's speckled is also called tiger top or mottled top, MOTTLED. All right, I think, you know what? It's already like 11:30 and I went through a lot. So we'll continue next week on the order of draw. Or you can also look up this diagram here and then Google what the order of draw is. And then I will put in the announcements for today along with this video and also the links to the 2 videos that we had, the ones that I got from YouTube. And I'll do like a little take-home assignment. And remember, the take-home assignment, I believe I put it here in announcements. Just remember, check your announcements always, 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 because I didn't get anything yet from anybody. So where did I put it? Did I put it in here? Yeah, I put it in the week 6 Zoom session. And I don't know why it did this. Made it super big, but it did. Right. So it's right here. And it's Ekg Homework. And just email me, or you can email me this file with and make sure you put your name on it and today's date. And remember, it's due today. And you could just highlight your answers. Okay. And it was based on the lecture. So it's at this point, any questions, comments, or recipes? If none, I'm going to stop the recording.